La letalidad global lentamente va ascendiendo en los distintos países. La siguiente.
All right, so we have begun with the daily technical report, and we are looking at the data now internationally of the past 14 days. As we have observed in the past few days, the Americas are now showing greater representation than the European region. And this is the situation for Mexico. Since the first case that was detected January the 28th, we have accumulated 8,261 cases. These are people who have been confirmed by laboratory tests to be positive for COVID-19, and unfortunately 686 people have died because of this disease. We have studied an overall of 49,570 cases, and we can look at the distribution per state. We have areas that have higher concentration of the disease than others. Of course, they are represented in orange tones. As to those who have low concentration levels, they appear in green tones. We can look at the same information displayed on the form of a bar graph. Here we can appreciate the number of cases per state. And on this map, we can take a look at the accumulated incidence rate, meaning comparing properly the different populations of each state, the amount of confirmed cases. Then we have a statistic that is called accumulated incidence rate, and this is better to compare the intensity of the disease in different states. We haven't seen any substantial changes the last few days, and this is the same idea that we have been talking about for the past 12 days, which is that the Mexico Valley City area, the Guadalajara metropolitan area, and the most populated areas within the Baja California Peninsula, as well as the Quintana Roo state, those are the regions that we have encountered more transmission of the disease. Same information, we can look at it through a bar graph to visually appreciate the accumulated incidence in each of these states. We have Mexico City that is leading the way, then we have Baja California state, and then the rest of the other states. This is the municipality map. This is public access information. Everyone can access to this map through this URL that appears down below. In this map, we have concentrated all of this data that we're presenting. And it's an interactive map. If you enter the website, you can see the specific number of cases per municipality. This is the distribution per age group. This is the same message. Those senior citizens have a higher proportion of cases or of infected patients that need to be hospitalized. That is why the yellow bars represent inpatients, meaning people who require hospitalization, and the green bars are outpatients, people who do not require hospitalization. So, with the age groups below 60, the biggest proportion of cases are outpatients, but those after 60, then most of the cases are inpatients. Of course, as we have said repeatedly, the biggest risk factors, aside from age, are the existing preconditions, diabetes, obesity, hypertension, and all of these are related to bad nutrition habits. But we have emphasized that these bad nutrition habits do not have to do exclusively with bad choices by individuals. They have to do with an oversupply of bad foods in our Mexican market. We have a lot of available foods that are of very low nutritional value, and they are very high in calories and in sugars. So that is a structural problem that we have to address. Now here we have the proportion of the clinical status of the hospitalized cases, meaning what was the clinical status when they entered the hospital. We have 63% entered as outpatients, then 11% are hospitalized but they are stable. We have 21% who are in severe condition, and 4.58% are intubated patients. Today, Dr. José Luis Terán will be sharing with us some data regarding this phenomenon, in which these people who arrive to the hospital and they are already in severe condition, a proportion of them need to be intubated. But fortunately, the great majority of them start recovering, and then they are eventually discharged. Next one, please. When we take a look at the suspect cases and the confirmed cases, we'll just leave you with this data, and this data will be recorded in the live transmission, so let's not go into further detail. I just want to emphasize that those patients that are cataloged as suspect cases, the only difference between those and the COVID confirmed cases are the results. Meaning suspect cases are still waiting for the results, and then after the results come out, they're either cataloged as negative or positive. But their clinical status is identified from the very moment they are cataloged as suspect cases, and this status can be related to certain symptoms such as throat aches, coughing, fever, etc. Or maybe they are in a more severe state, that because they have a clinical syndrome, which is pneumonia. We were explaining about pneumonia yesterday. We won't be into further detail today, but we have identified a number of lesions that have to do with COVID, because remember, COVID is a virus that circulates all over the body, and it causes some other damage to the body. And there are different kinds of damage, including obstruction of blood basins. Yesterday we were explaining about how the body damage that is inflicted by the virus can be divided into inflammatory damage and obstructive damage. We will prepare in the following days, and we'll be inviting Dr. Reyes Terán to present us with more information regarding these other manifestations of the disease in our bodies. The unfortunate fatal outcome of the disease in those cases in which the patients do not recover can of course lead to the patient losing their lives. And it is important to keep track of the fatalities, because it helps us understand the gravity of the disease and the overall trend of the epidemic. Here we have the characteristics of the disease, or the clinical conditions. The comorbidity is the same, it hasn't changed. As we can see, the percentages are the same, they are identical basically. We haven't identified any other diseases. Leading three are hypertension, diabetes, and obesity, and then we have smoking, kidney failure, immunosuppression. But today I want to focus on one, because it talks to us about a community that has been in a vulnerable position for a while now, and that is HIV positive patients. Remember, HIV positive patients can now have a very good life quality if they are treated properly, because now we have the drugs to do so. But unfortunately, a lot of people who live with HIV in Mexico, they are unaware of it on all the way to the point where they have very, very severe consequences on their immune system. What I mean by this is this HIV, this virus, inflicts great damage on the person's immune system, and one of the outcomes is immunosuppression. We know from a variety of studies that have been carried out, we know that up to 50% of the people who live with HIV in Mexico are unaware of the fact that they have HIV, and they become aware of it when they develop some sort of infectious disease and they have to go to the clinic. Even though COVID is not considered what we call an opportunistic disease, that is a clinical term for it, even though it is not considered to be one of these diseases, eventually COVID will be cataloged as an opportunistic disease that could be potentially more dangerous to a person that lives with HIV. So I want to remind everyone of the importance of testing yourselves for HIV, especially in those communities that have a higher frequency of HIV infections. And this is very important because the resources to get tested for HIV in Mexico are completely free of charge. They are available to you through the different medical units in your city or in your state. And it's very important that you identify early rather than later the condition of being a carrier for the HIV virus, so you can take the relevant precautions. Unfortunately, we've had some people now with HIV that have died directly as a consequence of COVID. Here we have the mortality and lethality rate. So as you know, the blocks are the overall number of deaths. The blue blocks divided by age group, but the green line represents the fatality rate. So we can see how the fatality rate is higher in older populations. So far we have had only one case of a minor who was under 25 and died because of COVID. This is rare, but it can happen, especially when the person has some other condition such as immunosuppression, which was the case for this child. Here we have the overall fatality rate that shows great variation amongst different states. And here we can, for example, we see some states have a very high fatality rate and some other has a lower fatality rate. And we wanted to be clear that the states that have a higher fatality rate, this could be a reflex of a delay in seeking medical treatment from the side of the relatives or of the people who are exhibiting symptoms. Why do we say this? Because the time will come in which our health system is saturated or overworked, and maybe we are struggling to provide treatment to all of patients that need it. But we haven't reached that point yet. We don't have an oversaturated system right now. So these fatality rates could indicate that the people are taking too long to go and seek for medical attention. So I want to make a call to all of those people who exhibit symptoms such as coughing, fever, nose running, to have a runny nose, who have red eyes. If you present a risk factor such as being a pregnant woman, a person over 60, or having obesity, hypertension, diabetes, being a smoker, being some sort of having some sort of immunosuppression or kidney failure or liver failure, if you have any of all of these risk factors and present any symptoms, Do not wait any longer. Go seek medical treatment at your medical unit. If you don't belong to these vulnerable populations, you don't have to immediately go to the clinic. But if you have any of these risk factors, then yes, you do. Yes, you have to go, because you are at risk of presenting complications, and the longer you take, the higher the probability of you going into a severe state of COVID. So here we have the mortality rate, which, as we had said before, is calculated on the basis of each state population. This one is the proportion of people who, being suspect cases, are tested and then turn out to be positive for COVID. It's a fifth so far, it's 20%. This information will be changing every week, and we'll be reporting this every week. If we don't have any variation in the data, then we won't be reporting this chart. Finally, we have an aggregate of the different curves that we used to present separately, because we want to show you a visual appreciation of the overall evolution of the different trends. We have orange, we have the suspect case curve. On red, we have positive accumulated positive cases. Green line, we have the accumulated recovered cases, and on the black line, we have the fatalities. Both people who have the disease in the mild version of the disease, but also an important proportion of the people who have the severe version of the disease, even though it takes them a lot longer, but both of them can recover eventually. And we can see this at the difference between the two curves, because we have the suspect case curve, then we have the positive case curve, as I had explained, and then we have the recovered curve, the recovered patient curve, and then we have the fatalities. So this distribution can be distributed across 14 days in case of a mild version of the disease, and longer in the case of more severe version of the disease. This is the same. We wanted to present it in further detail. These are the recovered cases, 3,087 so far, that account for 37.84% of the overall confirmed cases. Here we have the epidemic curve. We have an increase of 10% with respect to the day before. And this percentage is a significant amount of cases. Even though if we are augmenting, remember that exponential growth, what it means is, if we are increasing 10% every day, that 10% is larger and larger every day, because that 10% is being calculated on the basis of a larger amount of cases every day. So we have to take it seriously. Remember, the epidemic hasn't ended. Do not get confused. Please do not think that the epidemic is over, that you can go back to working, that you can go back to your normal activities. No, absolutely no. That is why we decided that the massive mitigation measures and the safe distance journey will be extended until May the 30th. Do not think for any reason that the epidemic is over, or that is going down, or that we are slowing down in the rate of transmission. No, we are not. We are going up. We continue to go up. And this is not something that we wanna get confused about. the contagion will continue. And what we want to do is to slow them down as much as we can. The opportunity hasn't been lost yet. The opportunity is still there. Stay at home. Stay at home. Stay at home. This will remain until May the 30th. Thank you. Good evening, and thank you, Dr. Hugo Lopez Gatell. I want to show you let's talk about the medical treatments and the medical attention that we've been giving the COVID patients. We know that the people who have mild symptoms or moderate symptoms, the best way of treatment is to do home isolation and to abide by the public health measures that we have been insisting on. So I'm going to be focusing on the other kind of patients, the patients that are in a severe condition. I'm going to divide them into two groups. The non-critical ones, meaning the non-critical patients, they do not require an intensive care unit. They only need a hospital bed, and they usually have a better chance. But the other part is the patients in critical state. These patients are the patients in the most severe condition. They require an intensive care unit, and this unit means having a room that needs to have specific characteristics. It's not any room. In this room, the patient most likely will be intubated. He will require assisted mechanical respiration, so they will require a ventilator, and they will require infusion pumps, at least 4 or 5 per patient, so they can be constantly receiving medication to keep them in a stable situation. Remember, these patients are showing organ failure, and they also require to have better and more strict personal protection measures and equipment. It is very important to remember that the equipment that is being used by medical professionals, in these rooms is very specialized medical equipment. So the premise regarding this situation is that we don't wanna we wanna organize in a way so we can provide treatment for each patient. So there are no patients that go unattended. Over the different hospitals and medical units that we have in Mexico City and over the country, and talking specifically about the national health institutions, the national health institutes, we have 26 overall. In total, we have 10 that are seeing COVID patients, and we have another amount that are not seeing COVID patients. Especially, we selected the National Institute for Respiratory Diseases to focus on the COVID patients because they had great experience with the epidemic of influenza that we had in 2009. Few people know this, but the INER, the National Institute for Respiratory Disease, reconverts their hospital, so to speak, according to the season. So, during the influenza season, some areas of the hospital are converted into intensive care units to be able to expand their capabilities and treat all the influenza patients. Now, the second hospital I want to talk about that was elected as a specialized COVID hospital was the National Institute of Nutrition, as well as other hospitals like the Heart Medicine National Institute, and also the specialized hospital of Ixtapaluca that has a strategic position. And we look at the next slide. So I just want to emphasize that what is the unit, the fundamental unit of an intensive care process? We have the patient, we need to have a monitor, infusion pumps, ultrasound machines, ventilators, a bed, and all of these equipment and all of these protocols are required to provide treatment for one patient in critical state. And very importantly, there need to be highly trained and highly specialized medical professionals that are able to operate this equipment and that are able to monitor correctly the condition of these patients. There is a low percentage of patients that have kidney failure. So it is important that any intensive care unit has the proper equipment for hemodialysis if it would be necessary, in case it would be necessary. The hospital reconversion in these hospitals that I just named, and I want to say thank you to all of the general directors, and not only to them, but also to the area directors, the medical directors, the teaching directors, the administrative directors, and of course all of the personnel, the health personnel, the medical practitioners, and specifically the resident doctors in the COVID hospitals that are providing direct treatment to each of the critical state patients, and they have been trained so they can operate the personal protection equipments. And of course, they are all highly qualified and trained to provide the best of the best clinical attention to these patients that have COVID-19. Not only to them, I also want to thank all the nurses and all the nurse personnel. Their labor has been fundamental, has been crucial. We need more of you, we need more nurses, so we can properly cover all of the necessities in the hospitals that are currently under reconversion process, so we can expand our capabilities, and specifically when it comes to the intensive care units. Let me show the data we have so far. The intensive care beds, the total of available intensive care beds with this fundamental unit is 526, and it continues to go up. Next week we will get 200 ventilators and monitors. 150 of them are going to go to the Mexico City and Mexico State area, and they'll be distributed in 60 in the General Hospital of Mexico, 50 in the Hospital of Ixtapaluca, 25 in the INER, and 15 on the National Institution of Medical Sciences and Nutrition. In total, 150 ventilators and monitors that will be distributed. This distribution was planned according to the capacity and the reconversion capacity that each of these hospitals have, so we can increase the number of beds all the way to add 150 beds to their current capacities. The occupied unavailable beds so far are 449. Available beds only 77, but then let's increase that by a factor of 120 because we're under reconversion still. If you see any discrepancy in these numbers with numbers that we have presented previously, we are considering suspect cases and confirmed cases for these calculations. It's very important that you have this, you have clarity about this. I'm not going to be considering the capacities of the IMSS or of the Army or of the Pemex hospitals or of the private sectors. They also have a number of available intensive care units, and they are already undergoing reconversion to expand their capabilities. But I'm not taking them into account right now. So what is the plan in case that we have a saturation? And like it has happened already in some areas, and that became public yesterday in the metropolitan area of the Valley of Mexico. There's some areas that have been saturated. So our proposal is to use the beds of the federal hospitals, of the regional hospitals, of the national institutes, and if we were in the situation of a saturated health system, other institutions would receive these patients even if they don't have medical social insurance to cover the demand that will exist during the upcoming weeks, and this would give us enough time to finish the process of the hospital reconversion program that is currently being implemented. This is not an easy mission to expand the capabilities of the system because it involves a lot of different factors. We have to make sure that we have enough electricity, that we have enough air pressure, that we have the proper facilities, the proper infrastructure within each hospital. So we are working currently to expand these capacities, especially in two hospitals that are INER and the Nutrition Institute. And this would allow us to have an extra 300 beds for the intensive care units, if everything goes right. And of course, we are waiting for the ventilators and monitors that are fundamental to close the cycle and have this maximum capacity that we could have to provide treatment for the COVID cases. I think that's enough for today. Thank you. Thank you, Dr. Reyes-Terán. As you can see, all the aspects of the epidemic are evolving according to different moments, and all of the different measures that we are implementing are taking into account the development of the disease. Today we were talking about some specific information regarding the number of confirmed cases, suspect cases, etc. Dr. Reyes-Terán has updated us on a subject that we have discussed many occasions before, which is the strategy of hospital reconversion that we have been implementing in several weeks ago, and that has allowed us to expand the capacities of our medical system. But let's not forget that all of this is what happening to a society, to a people, to persons made of flesh and bones that have desires, that have necessities, that have illusions, that have fears, and they're all together collaborating to slow down the epidemic, making huge sacrifices in their quotidian lives, in their incomes, in their daily development elements. And for this reason, Dr. Ricardo Cortés Alcala wants to show us a video so we don't forget about the human side of this epidemic. Thank you, Doctor. We've talked about how the mobility has decreased. Yeah. Of how there was a decrease of 66% of entertainment and purchases, 54% of the visits to parks, public parks, and 40% of decrease of work-related mobility. But sometimes numbers are cold, so we want to show some faces of all of those people who are artists, musicians, who engage in commerce, who have restaurants, who work at restaurants, who have small businesses, all of you who know that health is the most important thing, and taking care of all of us is the most important thing. We know the sacrifice you are making. We have we still have a ways to go, and thank you for being with us in this health distance program. But now more than ever, we ask of you to continue to stay at home.
Vamos bien y vamos a terminar mejor. Muchas gracias.
We're doing good, and we'll be doing better. Thank you very much. Let's begin with the Q&A period. You and you and you and then you. You asked some questions yesterday, and so then you and then you. Good evening. Doctor, it's been a few weeks that we asked the citizens to wear face masks, especially in public transportation, but there are several people, many people who have some sort of fabric that they use as masks, scarves, or some like cloths. How effective is this? And how many HIV patients have died because of COVID? Thank you. Regarding the second question, 5 people. 5 people have died so far from COVID who were also infected with HIV. Let me be very clear. Not all of them who live with HIV have immunosuppression, but there is an important proportion that do. So, and there is a lot of people who don't know who have HIV, and sometimes it is too late when they find out, because then they have some damage inflicted on their immune system. So it is important for all of us to get tested. Regarding the mask and some people who uses plastic mask and even like cloth masks, we think that this is a useful prevention measure. We've said many times that the prevention mechanism in this scenario is that the people who have COVID are spreading the virus through their saliva, through their secretions, and if these secretions get caught in a physical barrier like a mask, either that be cloth or plastic or whatever, well then it can be a contention measure. The quality can vary, but it helps. Now, it is not a mechanism that should you shouldn't feel protected by a mask just because you're wearing a mask. Don't feel like you're immune to the virus, because it's not the case. Regarding the other 2 questions, talking about the masks, it could either, if you're not wearing the masks properly, it could even have negative effects. Because if you're not washing your hands frequently and you're touching it, then it can become a source of infection. So if you're gonna wear a face mask, please do it properly. put it on, adjust it right to your face. It should cover your mouth and your nose, and you shouldn't be touching it at any time. It is not easy to keep a mask on these conditions. So, and talking about HIV, the people who have HIV and they are under retroviral treatment and they are under perfect control and very stable conditions, all within normal parameters, they could have, if they get infected with new coronavirus SARS-CoV-2, they could have a result that is very similar to those people who do not have HIV. And it has happened. We have had over 10 people who have HIV who have become infected with COVID, and they have recovered because they are currently being treated for their HIV and they are perfectly controlled. Good evening. You were talking about saturation that already exists in some hospitals in Mexico City and the state of Mexico. You're talking about 527 extra beds for phase 3 and some ventilators. Where are the ventilators coming from? And is this number correct? Are they going to be enough for phase 3? The 527 beds are the available beds right now. And that doesn't include, of course, the beds that are already occupied by some patient. But then we're going to be adding and it depends of we're going to throw another 200 beds with the arrival with ventilators, and then if we complete the overall hospital reconversion program, then we can be talking about 950 beds in total. And talking about the hospitals that are part of our coordination program between Mexico State and Mexico City, and taking into account the Hospital Belisario Dominguez, Hospital Enrique Carrera, and Hospital in Tláhuac, and there are 4 or 5 more hospitals in the state of Mexico that will be joining this total reconversion. And this is not taking into account the beds that are available and the ones that will be available at IMSS, at ISSSTE, at PEMEX, at the Navy, at the Army hospitals. We're not talking about those right now. The ventilators are going to be coming from China. We have many flights that are still will be arriving in the future. Do not think that we have a fixed number of flights that will be coming, bringing equipment. There will be as many flights as we need in order to supply all of the required equipment. We established this air cooperation bridge. This is called a bridge because the plane lands in Mexico, unloads the supplies, and then flies back to China, and then comes back, and then flies back, and then comes back, and then flies back. That's what a bridge means. So today we have Dr. Reisteran with us, and he's been in charge of one of the elements that was very important and that was activated early on. That was the program of Federal Hospital reconversion. Most of these hospitals are in the metropolitan area of the Mexico Valley area, but this is a first, the data we're presenting is a first expansion and first increase of beds as a result of the reconversion program. On a larger scale, we also have extra beds from IMSS and ISSSTE, and the directors of each institute are coordinating the reconversion of these 2 institutions, and this is all over the country. For this reconversion to be successful, each of the states will coordinate with their own state authorities. We also have an agreement with the private sector to have an additional amount, an additional number of beds. We are also in close cooperation with some entities in Mexico City, for example, like the Banamex City Center, that will be used as a new as a temporary hospital. Every time we say data like this, please be aware that this is only a small part of an overall strategy that encompasses contributions from all sectors. All right, we have 7 minutes to go.
Buenas tardes, doctor. Héctor Mireles para el canal.
Good evening, doctor.
Glucosa atómica y doctor Politécnico en Facebook. ¿Han considerado ustedes
Have you considered inviting some officer from the Ministry of Education so they can explain what's happening with the school calendars and the situation of the children? Or is this gonna be is this information going to be presented on morning conferences? Now that the Ministry of the Interior has admonished or warned this TV station that gave this message for disobeying you, are you thinking of taking any measures as the Ministry of Health? The second question, just the same answer that I gave yesterday. We are focused on what we must be focused on. Everything else that means to distract us from our objective will eventually pass, but we are focused on an objective that is the control of this pandemic. And talking about the Ministry of Education, the Secretary of Health will be here on Tuesday on the morning conference, and he will be presenting that information regarding the adjustments to the school calendars. On Friday, we had a conversation that was very productive, in which we identified how this activity of these modifications to the school calendars that are a consequence of the suspension of classes are developing. And remember, this was a very important early measure because it allows us to reduce the number of people in the public's case by 50 million. So he will be coming to the National Palace on Tuesday. He is also a member of the General Health Council, so it is crucial to have this collaboration with them. Thank you. Right, one more question.
Buenas noches a todos. Soy Gerardo Suárez, reportero en El Heraldo de México.
Good evening, everyone. 2 questions. The first one, which measures will be adopting regarding the 10,000 workers of Capufe who are still operating on the payment stations of the federal highways? And also, we've received some report of scarcity. Well, regarding these same workers, they do not have access to any personal protection equipment, and they have to interact directly with the drivers. So, what's going to happen with them? And also, in the time we have to come, we're still waiting to enter phase 3 and the most critical situation. So how many intensive care beds are you estimating to have in total, taking into account the federal level, the local level, IMSS, ISSSTE, all of that? The second question, these numbers are being presented periodically. Let's wait for Tuesday, because in Tuesday we will have more data and more updates on all of these collaboration agreements and interinstitutional efforts. And talking about Capufe, yes, the highway activity is an essential economic activity, and that is how it is considered on the agreement of March 31st. The activity of the highways must not stop because it's the activity that guarantees the logistics of the distribution of all public life, including the supplies for hospitals. The medical measures, the prevention measures are the same. They do not require specialized protection equipment, just the same as the cashiers in supermarkets or people who work at banks. They do not require specialized medical equipment. They just need to abide by the protection measures. We have the guidelines for the protection of such workers that were designed with the collaboration of the Ministry of Tourism, the Ministry of Economy, etc. And each public's case has its own unique technical protocol for the prevention and control. Could we think about a payment method that is not cash, for example, to protect the health of these workers? This would have to do with the Ministry of Transportation, so maybe they will have something to say about it later. Yesterday, we had a report of a person who died from COVID in the area of Miguel Hidalgo. He had mild symptoms, and then he was indicated to stay at home. Then he started exhibiting more severe symptoms, so the family asked for an ambulance, but then it took too long. So when the ambulance arrived, this man had died already. When the ambulance arrived, they said they didn't have enough equipment to properly transport the dead body, so they had to wait for 10 hours to transport this dead body. Also, there was no one who monitored the state of these relatives of this person, because the cadaver was tested and it turned out to be positive, but no one informed the relatives, no one kept close contacts with them, no one sanitized the home. So how many people are dying in their homes, and what would be the reason for that? And is there any protocol to handle these situations? Thank you. What an unfortunate situation. And of course, because of the person who lost their life, but also because of the relatives who have to be under such stress during this period of time. So let me insist again, those people who have some risk factor, over 60, pregnant women, chronic cold disease, go to medical consultation. But also, those people who identify who have difficulty in breathing, we've reminded the population of this element. Do not confuse, do not conflate respiratory insufficiency, meaning difficulty to breathe. That is a medical term that is used to describe the sensation of not having enough air, of lacking oxygen. So becoming very tired with minimal effort. So going from the kitchen to the living room and feeling fatigued, that is a sign of shortness of breath or respiratory insufficiency. Also, if you're making a more intense effort in order to be able to breathe, then that is not normal. Even this, if you have to make an effort with your lips in order to be able to breathe properly, these are clinical symptoms. Also, looking pale. Also, if your skin looks purple or bluish, that is a severe symptom of an oxygen insufficiency. So let me remind everyone who could potentially have COVID, even if you don't have any signs, even if you don't have any risk factors like age, being pregnant, or having pre-existing conditions, if you have shortness of breath, if you have respiratory insufficiency, this is reason enough to consider it an emergency. And talking about the people who could die at their homes, this happens not only with COVID, it happens with influenza, and it happens with other diseases. And whoever dies at home, if this is not registered, if this is not notified, it obviously doesn't come into the registry. But the important thing is not the notification. The important thing is that they get treatment. So any person of any age, of any clinical condition, if you have shortness of breath, you have to go seek for medical attention. If you have any doubts of where to get treatment, call 911. 911 is the national emergency number. Since a couple of months ago, there's been a protocol of training to the personnel that works taking the calls from 911 so they can provide orientation regarding COVID. So if you're not clear on where should you go, for example, you used to go to a private practitioner and now it's the middle of the night and you don't know who to call 911. It's an emergency situation. You will receive the proper orientation. I think that is the last question. Thank you very much. We'll continue tomorrow.